You're on? Okay. You just double check Facebook on or not.
Should I stop sharing and change to Hishamshah face?
Sudah go live kan?
Ada bulan. Sekali kedua.
It should be which screen?
You should be Hishamshah.
Yeah, now you do that. It's connection of here.
Facebook is okay.
You just looking for other people to come on board.
Topic first. Yep, YouTube is here.
Okay, both on.
Twitter is in also. All in.
Okay.
Yeah, have to.
Yeah. Thank you so much.
They're using pelip-pelip punya port. Tapi now dah okay lah. We allow already. So
Okay, thank you so much.
I can see that. I'm in and out from the one meeting to the other. I was here like about 6:30, 6:40. I'm already in Putrajaya. There's only 2 blocks, which is not bad. I thought if I follow the north south highway, the roadblock is longer because the queue, is quite long. So when you use the side roads, it's better. There's only 2 roadblocks, and fortunately, in the morning, the queue is not so long. So how many people is actually already on board? I mean, participants, we've got a lot. Yes, definitely. the presenter slide and a summary of the panel discussion and Q&A will be available on all of our social media platforms, Twitter, Facebook, and also on the Paediatrics website. If you like to watch this session, you can go to our YouTube channel and the podcast version, which is only audio. It is available on major podcast platforms. For example, like Google Podcast and etc. Please do follow our Twitter account. The handle is @cleanup, CLIN up _COVID for the latest information. So this COVID-19 webinar is using echo style, which means we dive straight into the presentation and keep the introduction as quick as possible. We will not be giving lengthy introduction of the speakers like the usual conferences. Unfortunately, just the name, designation, hospital, and title of presentation. So I think now we are entering the webinar proper. So I'd like to welcome everyone to the webinar. This is actually the clinical updates in COVID-19. Thanks to CLC, we are now joined into this clinical updates by several eminent panelists. And the topic for today's discussion will be managing COVID-19 in pediatrics and pregnant ladies. To start off the agenda, the first speaker would be Dr.Norashikin, Mohamed Fuad. She's actually the head of Department of Obstetrics and Gynecology at Hosp.Sg.Buloh, consultant obstetrician and gynecologist, and she will be joined by Dr. Mohamed Kasim. Are you there, Dr. Norashikin, Dr. Nohana from Hosp.Sg.Buloh? You are there? Okay, give us a wave. Okay, that's it. And the topic that you will be presenting today is mothers with COVID-19. So without further ado, can you start off the session over there in Hosp.Sg.Buloh? Over to Hosp.Sg.Buloh now.
Okay. Hishamshah, I would like to allow Dr. Nohana to do the presentation. Thank you. Good afternoon, everybody. I'm Nohana from UNG in Hosp.Sg.Buloh. Basically, I'm going to present one of our cases. I think it was the first patient with COVID positive who we ended up coming with severe infection for her. One of the first patients who had a total of 8 patients who has delivered in our center. 7 of them were by severe infection and only 1 had generally delivered by vacuum extraction. 4 of them were COVID positive, the rest were P1. Our patient was Madam N. She was a 31-year-old lady who came on 18th of March 2020. She was a gravida 2 para 1. When she came to us, she was taking 6 weeks plus 5 days period of pneumonia. Her complaint was a history of 2-day history of fever, cough, and myalgia on the 17th of March. She had previous scar in 2015 severe infection for breech and preeclampsia. She also has maternal obesity with a BMI of 29.2 kg squared. She had anemia and pregnancy with mild and BPM 9.8. She has continued her pregnancy, but she remained normotensive and pregnancy was found to normal. We also had an ultrasound QB which is normal also. So her contact history was on the 7th of March, she had a contact with a relative who was positive COVID-19. She remained quite well until the 16th of March, where she started to have fever, cough, symptom, and followed the next day by having diarrhea, nausea, and a bit of breath. She wasn't in labor and hospital most good, so she went to hospital Ampang And because of the history of contact and URTI symptoms, was referred to us as a PUI. The first swab was taken here and was positive. On and was comfortable with alert and conscious, vitals were stable, she was not tachycardic. She was not dyspneic and she had no fever. Her chest lungs were clear. The chest X-ray, when we reviewed, we thought we saw possible pneumonia infection on the bilateral dual zones. So the impression at that time was she was COVID positive and really this was the chest X-ray, it might not be clear to you guys. This was taken on day 2 of admission, it was admitted on 17. Before the report came back, it was taken as 3A. However, when the report came back from the radiology, the report said that there was no significant radiographic abnormalities. So the device diagnosis was good.
Where's the screen?
So the classification for COVID, everyone is asymptomatic. I think by now everybody knows this. Okay. This is the treatment that we give according to the stage. I think so the progress of the patient. On the 18th, she complained of significant movement, and on the death toll, it showed that the hospital bradycardia. However, the CPT was reassuring, but because of the hospital was near the COVID and reduced movement, the patient was sent for elective immunization and improved. The surgery was uneventful. The baby was in presentation, the baby had 2 size baby, 2.6 kg, put up the score. The placenta was disposed as per protocol. The baby was handed over to feed, and the mother at that point was advised not for breastfeeding. Subsequently, this is the swab history. The admission swab was positive. The subsequent 3 swabs were positive also, but the day 13 swab came back negative. She was discharged the following day. She remained asymptomatic up to the day of discharge, and we advised her to home quarantine for another 2 weeks, and we will be seeing her in KK time.
So the baby was delivered by rapid cesarean section for COVID-19 positive mother in labor. The baby was premature at 36 weeks, 5 days, birth rate of 2.65, and appropriate length and first cycle stop was good, 9 and 10, and the blood screenings were all normal. The normal vitamin K and vitamin C. Usually, as the protocol was attended by pediatrician with PPE and PPR December, you need to do any aerosol generating procedures, and you was admitted to our NICU in special isolation room with negative pressure, accompanied by staff nurse and other healthcare workers in complete PPE. So the genome detection test was done at day 1 and day 14 of life. Patient going to go on today, so we will do the last delivery, and it was not detected. The baseline blood that we took for this baby did not show any of the classical signs of COVID-19 infection, such as leukopenia, thrombocytopenia, raised CRP, or transaminitis. The nursing care was done as per routine, and feeding and vital signs monitoring was with PPEs in the isolation room. And after the first week of life, the baby was quarantined in the quarantine area out of the isolation room, as the babies need to drop out of the isolation rooms from the much better than the PCR test is negative. And like the baby was fully discharged without any issues at 2 weeks of life. So far, the cumulative COVID-19 patients in Sg.Buloh, we have 3 units of COVID confirmed mothers, which turned out to be negative. In the general pediatric side, infants number 6, we have a few toddlers, up to 7 of them, and the more than cholesterol, total 9. So we have a total of close to 25 patients in Hosp.Sg.Buloh hospital itself. Next one. These are some of the blood investigations for the pediatric COVID-19 positive patients in Hosp.Sg.Buloh. The first two was patients from the Chinese cohort from Singapore. This one passed the one in Kwee and Silvan. Was our first backup for the initial 4 pediatric patients in Malaysia, and they were all quite asymptomatic. And as you can see from the current cohort that we have up to number 22, most of them do not have much of leukemia. No thrombocytopenia noted. The CRP was not raised in all of them, and the ALPs and ALPs transactase were all normal. So all the babies remain asymptomatic. We do have one patient who had pneumonia, who actually is transferred to Hosp.KL, because here it's not we're taking stage 1 and stage 2. Once they reach stage 3, we certified our care to Hosp.KL as they have facilities there and much more attention there. But so far, most of them have been asymptomatic, except 2 patients that we sent to Hosp.KL about a week ago. Thank you.
Now I'd just like to share some of our experiences that things that we encountered along the way, questions that arose. So basically, it's all the timing of delivery, mode of delivery, what about the content, what happens to patients who are in imminent general delivery, patient of unsure status, what kind of PT is required, where to deliver, who to attend the delivery, all that. So basically, all these questions are addressed in the guideline. Now this is the latest edition 5, which came out on the 25th of March. I just would like to highlight a few. All designated hospitals which deliver any PUI or COVID patients should have an identified labor room, preferably with negative pressure ventilation, okay, to manage PUI and confirmation. And you should also have a designated OT. It shouldn't be a common OT with non-PUI patients. Patients in labor should be offered cesarean section as a mode of delivery until more evidence of safety of vaginal delivery is established. Handling of body fluids, specimens including placenta and patient apparel should be handled based on standard clinical precaution. So breastfeeding will be deferred until confirmatory diagnosis includes COVID infection. This is our the delivery suite in COVID ward. This is for patients who are actually, according to the guideline, if they are admitted 6 p.m. or more with immune delivery and there's not enough time for you to get to OT, you should have a designated delivery suite. And this is one that is basically outside our PAC. In the parking lot, we made a tent where patients will come with ostomy who might not even have time to go to the COVID ward. So they will be delivered outside. Okay, so the mode of delivery, like I said before, in view of the concerns suffered by the fact that almost all centers do not have negative pressure equipped labor suite, PUIs should be offered as cesarean section as the mode of delivery, unless the delivery is imminent, because we do not have enough evidence on the intrapartum management. The placenta is just treated like a normal RBG placenta, disposed by the hospital, not the patient or husband. For the PPE, this one is for aerosol generating procedures like for this intubation or that, but I think to note is surgery where high-speed devices are used. We do not use any high-speed devices, but during vaginal delivery, there are a lot of pushing and straining, and the patient sometimes do not comply with using a fund. So I think that can be of this also. Okay, so this is the recommended type of PPE. The preferred one is the APR, powered air purified respirator, isolation gown, like a Tyvek suit, gloves, goggles with face shield and shoe cover. This is the second option if you do not have the APR. It's just a Tyvek suit, N95 with goggles, gloves and shoe cover. And if you really don't have any, N95, ISO gown, gloves, goggles and shoe and shoe cover. During a cesarean section, you must minimize the staff in the OT. You should not have more than 6. Okay? So the specialist does a cesarean section with one medical officer to assist you. The NS and the NS medical officer, you must get a senior one to do the case. Okay? Because you do not want a failed final and you do not want intubation. One scrub nurse and one circulating nurse will also access baby nurse within and the nurse will get the baby and passes the baby to be waiting outside. In the ward, you might need to do a scan or a CTG for patients in the antenatal period. So you should assign one machine for the COVID and QI patients. You must wrap your machines and clean the machine after each use. Use a probe cover. If you do not have a plastic wrap for your machine, you can just use wipes after each use. Also, you need to designate the pathway where you transport your patients in our setting. It's just an ad-hoc area where you should not mix with clean areas.
Thank you, Hosp.Sg.Buloh. We thank you, Dr. Hishamshah. Thank you. The second presentation would be from Dr.Thahira, Jamal Mohamed from Pediatric Institute, previously Pediatric Institute, now Hospital Tunku Aziza. Yeah? She'll be talking on managing COVID-19 in children. Dr. Thahira, are you there?
Yeah. Assalamualaikum.
Okay. Please, you can probably now proceed.
Assalamualaikum and good morning. Okay. Thank you for the reserve for inviting me to give this talk today. Okay. I'll start off with what we know about the pathophysiology of COVID-19. Okay. The virus is novel coronavirus SARS-CoV-2 discovered in December 2019, and the disease is called COVID-19. This virus is extremely contagious, particularly when it's close contact between people, and then the reproduction number or ARNA is about 3. That means one person will end up infecting 3 more. What is the mechanism of infection by this virus? Virus directly infects cell via ACE2 receptor, and children's lung express ACE receptor less than adult lung. Hence, the infection in children seems to be less severe. Other than this direct invasion by this virus, there's also a thing called a cytokine storm, where there's a cascade process where the virus leads to increased level of cytokine that cause direct tissue damage, recruitment of neutrophils to tissues, and other pro-inflammatory effects. This can lead to ARDS. There are a lot of cytokine being implicated, but among them, what interests most people is IL-6. Disease complication, it can be pulmonary and extrapulmonary, and for extrapulmonary involvement, it can even lead to multi-organ failure and severe critical illness. Cardiac dysfunction can be due to virus-induced direct damage since cardiac tissue has carry ACE receptor or hypoxic damage. Other things that the virus causes will be pericarditis, liver damage, renal failure in severe infection. Clinical manifestation of this virus, incubation period ranges from 1 to 14 days, mostly ranging from 3 to 7 days. So hence the home quarantine for 14 days. Most of the children who turned out to be COVID positive had close contact with infectious cases or were from family cluster cases. No symptom on admission consistently predict outcome in children, though in adults, high fever on admission was subsequent development of ARDS and death. When you look at symptoms in children, majority of children were asymptomatic. If they have symptoms, the commonest one will be fever and cough, about 50% each, and fever in children tends to subside within 3 days. The cough is typically dry. If they are productive cough, only 3%. People also reported myalgia, lethargy, GI symptom of abdominal discomfort, nausea, vomiting, abdominal pain, and diarrhea. Clinical management of COVID cases. This is the clinical staging that was shown earlier. From stage 1 to stage 5, asymptomatic. Symptomatic, no pneumonia, where you have only upper respiratory symptom. Stage 3, symptomatic pneumonia. We also subclassify into A and B. 3A with fever, 3B without fever. 4, symptomatic pneumonia requiring supplemental oxygen. And 5, critically ill with multi-organ problem. Stage 2 and 3 can be further classified based on the presence or absence of warning sign. Usually in adult, it occurs after day 7. The warning signs are recurrence of fever or persistent fever, dropping absolute lymphocyte count, increasing CRP, and tachycardia. The next few minutes we'll be talking on the case. First case is an 8-month-old baby boy, admitted on 24th of March with no known medical illness, fever and cough for 4 days, with rhinorrhea, diarrhea for 1 day, and history of contact with grandfather who is positive for COVID-19 a week prior to illness, tolerating breastfeeding well, so he was admitted to COVID-designated hospital for further management. On examination of well-traveling baby, the temperature of 38.5, heart rate 160 beats per minute, spirit rate 55 per minute, mild chest recession, saturation 98% on room air, lung cause crepitation bilaterally, cardiovascular and rest of system examination normal. The clinical staging for this baby, COVID positive, with evidence of pneumonia without need for oxygen supplementation. Okay. This was his X-ray. Opacity bilaterally, very highlight area, no consolidation. Day 1 of admission, day 5 of illness for this boy, he had respiratory of 55, temperature 38.5, saturation 98% on room air, total white count is 8, lymphocyte 44%, CRP 15. By day 3, day 7 of illness, the temperature was 37.5, total white count 9.1, lymphocyte 58%, and he was referred for COVID antiviral therapy. The result for COVID-19 from the swab came back positive the next day, and by day 5 admission or day 9 illness, it turned negative, and then subsequent tests was also negative. Blood culture with no growth, and the rest of the panel for the viruses were all negative. It was referred for antiviral treatment for COVID-19 on day 7 of illness. Indication, symptomatic COVID-19, category 3, high risk group, because he was infant, and child was on antibiotic already. So, following ECG to look for QTC interval, he was after a combination therapy of lopinavir/ritonavir and also hydroxychloroquine. Child remained well with no symptom. RD antibiotic was continued and antiviral stopped at day 5. Second case, a 10-month-old baby boy, date of admission 26th of March, presented with fever and cough for 8 days, initially treated as URTI by KK in discharge home, presented to another hospital for tachypnea on 26th of March for 1 day. History of contact with parent positive for COVID-19 and referred to COVID-designated hospital for further management. was born more than diaphragm 36 weeks with weight of 2.1 kg with G6PD deficiency. On examination, is a well-thriving baby in respiratory distress, temperature of 38 degrees Celsius, heart rate 150 beats per minute, respirate 56 beats per minute, saturation 98% on room air, improved to 98% after 2 liters of oxygen, lungs cough crepitations bilaterally, and cardiovascular rest of system examination were all normal. So, clinical staging for this baby, stage 4, evidence of pneumonia and require oxygen supplementation. This is the X-ray. He also had bilateral perihilar opacity, left more than right, which is even worse from the first case. So, day 1 of admission, day 8 of illness, the respiratory rate was 50, temperature 38 degrees Celsius, saturation 98% on insuprom oxygen, total white count 10.4, absolute lymphocyte count 7.3, and CRP 11. By day 3, day 10 of illness, the respiratory getting better, afebrile, saturation 99%, white count 7.3, PANC 5.5, and CRP coming down trend. The test for COVID-19 that was sent on day 1 became positive, and by day 5 or day 12 of illness was negative, followed with another negative result next day. Blood culture with no growth, and then the panel for the other viruses were all negative. He was commenced on intravenous amoxicillin acid since admission and continued just before discharge. Initially, we covered him with oseltamivir until the result for influenza came back negative. He was not started with any other antiviral or COVID like the first case. Since by the time he came to us, his Kwee have already improved. From 4A, he became 3. He was able to off oxygen, so we did not start him only anti-COVID treatment like the first case. Sharing with you our cases that we've seen in Hosp.KL. Since we started seeing children investigated as UI in February 2020, we have total of 28 cases. But from this group of children who were travelers with their parents, none of the children came back positive for COVID. Number of children positive for influenza was about 10%, and for adenovirus 3%. Almost all treated for community-acquired pneumonia. Until yesterday, we had a total of 16 COVID positive children. All came from close contact of family cluster. Age less than 1, 4 of them, 2 to 5, 3, above 5, 9-year-old. Above 5, about 9 children, 56%. None have comorbidities. Majority of them were asymptomatic, category 1. Category 2, fever and upper respiratory tract symptom, 8%. And category 3, pneumonia, 12%. Mind you, our denominator is very small. Up to yesterday, we have a total of 76 kids with COVID positive all over Malaysia. For the next 3 slides, I'm going to put up principle and management for COVID positive children, starting from antibiotic. So paracetamol is still our first line antibiotic, which work NSAID, ibuprofen in children with poor fluid intake or suspected AKI. It's a theoretical risk of upregulating the ACE receptor. For fluid therapy, most children with mild illness do not require any fluid restriction. However, if the children have respiratory compromise, consider fluid restriction as this may reduce the risk of ARDS. For bronchodilators, this is not a common problem in children with COVID-19, so bronchodilators should not be used routinely unless there's strong suspicion of bronchoconstriction. If you want to use them, it's via MDI and spaces. Avoid nebulization is another procedure that generates aerosol. For antibiotic, used in children with comorbidities, and if they are unusually sick at day 1 of admission, or if they are not showing improvement by day 3, particularly fever or still on oxygen, or if they have BCRP or WBC, especially beyond day 7, that is the critical period. And if you follow the adult guideline, to anticipate the cytokine storm, we can have this baseline serum ferritin, D-dimer, and LDH. Antibiotic is also indicated in the feature of sepsis or if the child having productive cough. How about use of antiviral and immunomodulators? So there was no proven efficacy of any drug for human as of March 23rd, 2020. Chinese guidelines for COVID-19 suggest using chloroquine, traditional Chinese medicine, and for anti-IL-6 drug, tocilizumab, as an anti-inflammatory in patients with extensive lung disease, severe illness, and elevated IL-6 level. These recommendations, however, are not yet supported by robust clinical evidence. However, if your combo HIV drug, lopinavir-ritonavir, was widely used in China, but the first ever randomized control trial involving 199 adult patients in China yielded no benefit. Time for clinical improvement and mortality at 21 days, there was no difference between cases and control. How about systemic steroid? Systemic steroid should not be used as a treatment for COVID-19. For other antiviral, no trial of antiviral medication have been conducted in children with COVID-19. So the use of antiviral is not recommended yet in children. Currently, among the drugs going on trial, remdesivir is a drug used for Ebola previously and now showing good in vitro data where it can tell SARS coronavirus 1 and 2. And the other drug is in the pipeline is favipiravir, is an anti-flu drug used in Japan for flu A and B, which also show a lot of promise. How about our old anti-malaria drug? Chloroquine and hydroxychloroquine may have antiviral activity. The mechanism for this is unclear, but in vitro studies suggest it may modify virus receptor binding by interfering with the alkalization of the phagolysosome. So in children, among all the drugs that have used for adults, this show more promise. But it's unlikely to have any clinical significant benefit when given routinely, but may be considered in the rare event of ICU admission. But as we all know, this drug was first licensed to be used in human in World War II. So it has its all side effects. So you have to do ECG to look for QTC interval. It's contraindicated. You need to precaution if you have diabetes. You need to have to look for retinal problem and so on. And also a lot of drug-drug interaction, especially if you're using it with Calitra or lopinavir-ritonavir. We look at mortality per se. As if March 14, 2020, there was no deaths for people below age of 10. And if you look at the mortality rate in US compiled by CDC, there's also no deaths below individual less than 90 years of age, but now there's a change. There was recently a report of infants dying in US. When you look at children in severe COVID-19, there's a respiratory review of large group of children from China. Total children, 2,143 of them. Severe disease of category 4 is about 5.6%. Critically ill, category 5, about 0.6%. And one death among a 16-year-old adolescent. There are 5 key principles for good practice during the pandemic. One is reassurance. So if you're not convinced yet, children has milder disease compared to adults, In Italy, among 22,000 people with COVID-19, there were 1,625 deaths, but none in people younger than 30 years. In China, among 2,134 children with COVID-19, only one died. And we need to actively involve our parents, especially parents of children with comorbidity, but they also need this reassurance. And as a disease evolves, we might see new things, and we are not sure yet how our children with comorbid will perform if they are infected with this virus. So when they are in the hospital, we have to advise them to use masks, wash hands, and during this MCO, try not to overfeed our children and make them obese, and not expose them to smoking so that if they get this virus infection, they will not have it for that. Number two, minimize spread of virus in hospital by managing the children and adults in same facility so we can maximize our resources, PPE in an isolation room, and also minimize spread in community by having good infection control procedure even at home. Even though children have mild diseases, but they seem to secrete their virus in their oral pharynx and also their nose quite longer. So they might be implicated in continued transmission in the community. The other thing will be sharing data and knowledge that now we have to regularly see our Mod's website for COVID-19 update and also the other guidelines. Okay, this is my last slide. Thank you.
I've not been to the hospital for many weeks now. Starting in Putrajaya. Thank you for updating us from your experience dealing with babies, children with COVID-19. So next in the agenda is the update on post-delivery of a baby from the first case. For this, I think I would like to invite Dr.See Ching, our neonatologist, and also the head of department of Pediatrics in Hosp.Sg.Buloh. Dr.See, you've got the Zoom webinar to present.
Okay, thank you, Dr. Hishamshah. Hi, and good afternoon, everyone. We've discussed about the case just now in the first case that was delivered with a COVID positive mother on the 18th of March. And that was our first COVID positive mother who delivered this hospital. Subsequently, there were 3 other mothers with COVID positive confirmed cases delivered in this hospital, all by cesarean section. And so far, we have closed about 9 PUI cases, which was also delivered in this hospital so far. We have seen some horizontal transmission of cases from the community. We have 820 of live babies who also COVID positive and so far has been asymptomatic. And I think before they have a day 12 of life baby and was also admitted for the same reason. So the issues with the handling of perinatal COVID mothers is the degree of what we call it, healthcare personal protection that you need to have, and to arrange or to put your resources in place so that it is a seamless process that will benefit both the mother and also the baby and the healthcare worker. I'm lucky because the Hosp.Sg.Buloh is actually a 100% COVID hospital, so we do not have any non-COVID cases here. And our core business is just COVID patients, whether it's from the maternal side, the neonatal side, or the pediatric side. Plus, the patients who are stage 3A and above are sent to hospital for better management. And at the moment, what I can share with you is that you need to actually have, as Dr. Hannah said just now, a designated OT and also a team that can handle maternity cases that is due for delivery, and it actually takes time for these things to be assembled, for the process to be done, and also for the baby to be sent back to the isolation rooms. And hence, therefore, they have also mechanisms in place for the sudden admissions of mothers who are in immediate delivery that they do in front of the PAC. It's a special tent that is what we call it, constructed for this process. And if the patients are needing also intubation, none so far, then they also have the PAPR sets, and which the patients will be intubated in different ward before being sent to the OT. So all these things are in place to ensure there is a seamless management of the mother and also the baby post-delivery. Now, a few things about the neonatal resuscitation that you need to have in place. Things will change a bit. These are unusual times. So in unusual times, you need to have unusual decisions and also protocols. One of them is also the for the neonatal resuscitation, we tend to protect ourselves and from the baby. So far, none of the babies actually needed to be intubated and generate an aerosol generating procedure. In the case that the baby needs to be intubated, then we have the PAPR on standby, and these things should be done actually in a negative pressure room. And at the same time, we also have viral filters for our EPVs, our self-inflating bags. I think not many of us use full inflating bags, and we have a viral filter there. And most of the equipment need to be disposable equipments. And I think we thank the ministry for providing us some of these equipments that we can actually use in those circumstances. And we also avoid NIVs and also high-flow nasal cannulas in this group of patients because this is supposed to be aerosol generating. And for those which we need to intubate, our ventilators devoid of any humidifiers. Again, it's also the aerosolization of the gases and it's hazardous to the staff in the NICU. And for suctions, we need to use inline suctions or full system, and we're going to do open suctions. And if you have your light scope or video laryngoscopy, that will be an added advantage in this time of pandemic. And our team for intubations are limited numbers. We have specialists on standby. We have a senior MO who can intubate, and we choose the most experienced of the group that can attend the delivery. And we try to put any staff who has comorbidities, for example, if they are pregnant or they're immunosuppressed, to be in the team. And we have defined roles for them during the procedure, so that everyone knows what is going on. And this is very important as you are dealing with a potentially hazardous patient. There is planning before the patient is delivered. There should be good communication during the resuscitation process. And everyone from the leader to the other two assistants should have good communication rules. There's also sometimes good communication aids that we put at the side of the resuscitation table so that everyone can look at it from time to time, especially when you are down up, you are hot, sweaty, and sometimes you can't even breathe properly. You need to have aids to remind you on certain steps that you need to take. And that we provide at the delivery area where there's a cesarean, and we rest status of one patient which is delivered to the vaginal delivery. And so far, we have no issues with the PPE supply in this hospital, and that's the first thing that we highlight to all new personnel entering the NICU, that you must protect yourself first and learn to don and doff and use the required PPEs in any situation, and so on and so forth. Based on that, so far we have good outcomes in all the 9 PUI cases, and the three COVID positive mothers with their babies. One of them has already been discharged, and 2 are still in the ward. I think that's my update for the neonatal part of this telling updates. Thank you.
Thank you very much, Dr.C. I think this is actually a very novel situation for everybody. This virus is actually unknown, and how we address the virus is actually something that none of us have actually been prepared for in a sense. I think taking cognizance from our experience with SARS before this and MERS-CoV, and also the preparedness of our people in the front line, I think we have actually stepped up to the challenge. Just now we heard from Dr.Thahira how we manage children with COVID in our midst, and also you have actually first-hand experience of how you handle babies born out of mothers, with COVID-19, and it is very gratifying to note that babies born in this scenario can be well, and it is also very encouraging to know that they are on the way to recovery and they have been discharged. So that is coming from Sg.Buloh at ground zero in the COVID hospital. Next in the agenda would be the panel discussion. I think for the past couple of days, we collected questions from people. And then as we go along, listening into the discussion from Dr.Norashikin and Dr.Norashikin from the ONG department in Sg.Buloh, talking about mothers with COVID and how they delivered these mothers. And then I think we've got the question, which is actually coming up now. Okay, I need to read this question for everybody that's actually on the different channel. There is this question to Dr.Thahira. Dr.Thahira, are you still there? I can't see you and I can't hear you. I mean, are you there? Okay, you're there.
I'm here, Doctor.
Okay, together with us, I think we've got Dr.Tan as well as the panel member. Dr.Tan is actually our Pediatric Infectious Disease Consultant, who is now retired, and is now, I think, a professor in IMU, in Panellists University. So he's also on board today. I mean, is Dr. Tan there? Can you give us a shout or a wave or something like that? Dr. Tan, are you there? Dr. Tan
He's there.
You're there? Oh, okay, you're keeping silent. Okay, you're mute. So I think the first question to Dr.Thahira. Dr. Thahira, you mentioned that the virus targets the ACE2 receptors. Is that the angiotensin 2 receptor?
Yes, Dr. Hisham, it is.
Okay, that's the angiotensin 2 receptor. So this has got something to do with the pathophysiology of the SARS-CoV-2, yeah, which targets the ACE2 receptors, and then we can actually get the involution of the virus into the cells, and that's how you get the infection in the lower respiratory tract. Okay, the other question. There is a circular stating that all patients with SARI and pneumonia should be handled as COVID-19 patients until proven otherwise. So this is addressing the pediatric group. Is this circular also applicable to the pediatric age group? Can I have the answer probably from Dr. Tan? Because we need to listen to you. You're somewhere in Seremban, Dr. Tan?
Yeah, can you hear me?
Yes, we can. Loud and clear.
Yeah, okay, fine. Yeah, hi, okay. Good afternoon to all of you. I think under the present situation, under the pandemic, obviously there is no way we can tell whether a child who presents to us will have COVID-19 infection or not. In fact, we've had cases screened for COVID-19 but was negative, but actually turned out to be influenza A. So there are other kinds of infection during this current pandemic, which obviously you are aware, past couple of months there were problems with influenza for the last 3 to 4 months at least. So under the current climate, when you are not really sure and when you have COVID-19 around us, I think it should be until proven otherwise. So we need to do the screening for COVID-19, and then obviously if that is negative and this is a severe case, obviously then you would have to rule out other viral and bacterial infections. Yeah.
Okay, so the take-home message is treat all patients in the ICU, those with pneumonia, with SARI, as COVID positive until proven otherwise. Yeah. So that's actually the message that we're trying to send out. So this is regardless of whether it is pediatrics or adult patients. So given the current pandemic situation, we have got to be cautious. Yeah, it's better to err on the cautious rather than to be a bit more, easy going with these patients. Yeah. So that's actually the message by Dr. Tan. Okay, the next question. This is actually for our ONG team at Ground Zero Sg.Buloh. Caesar for only COVID positive patient. So this is the question. What about all those other PUI patients, or SARI, or patients with acute respiratory infection, and also with those with ILI patients? I mean, how would you actually address those category of pregnant patients due for delivery? Caesar as well, or standard way of delivery?
For COVID positive patients who are confirmed COVID positive, they have to do Caesar on them for now. And like I said, unless they are imminent delivery. For patients who have who are PUI, yes, we do treat them as COVID positive after birth. Yes, we section them, but if possible, we wait. Let's say something that 36 weeks with PUI. If we can wait until the swabs come back as negative or delay the delivery, then we delay the delivery and then we treat them as normal. But if there's not enough time to wait, let's say she's already 39 weeks and we need to deliver her and she's PUI, so we treat them as COVID and we do section them. But for other patients who are like as ILI or SARI, unless they have significant contact history or travel history, then do not treat them as PUI.
Okay, I think that's a very prudent kind of approach. We have to be very cautious. So if you suspect there is a can be potentially COVID, we can actually Caesar this patient. So that's good. Because sometimes there's some issue with the turnaround time for getting the COVID results. So it's better to be a bit more cautious. And totally acceptable. I think that's a very wise move. And you should be also quite careful when you're dealing with potentially COVID positive patients into surgery, because that's where you can probably get the aerosolization, and the healthcare workers need to be a bit more cautious. You have to take caution because you guys are the front line, and we cannot afford to get any one of you to fall sick. So please stay strong and please stay safe, people on the ground. We salute your work over there. Okay, for the next question, this is with regard to breastfeeding, yeah? Because any chance for the MOH to improve guideline in managing breastfeeding for suspected and confirmed cases of COVID-19 in mothers and babies? Who would you like to pick this up? Can I Dr. Angie side to answer this? Thank you, please.
Yes, I'm Dr. Nora here.
Dr. Nora, okay.
Yeah, regarding this question, of course, if you ask that there is whether there's any chance or not, of course, there's always a chance for this drug to improve the guidelines. But as for now, we do not have enough data. Although WHO can give some data to us, but the data is still not strong enough for us to ensure the safety of mothers and babies regarding breastfeeding. And of course, working under the umbrella of KKM, we follow the KKM guidelines. And as when the guidelines is going to change, then we will change our practice. Whatever is now, we are dealing with a bug which we are not sure of what is the disease progression. Therefore, we do not want to take any unnecessary chances on our own population. Therefore, please, I really hope that those people who are asking a lot of these questions on breastfeeding, please understand the situation that we are in now. We are not dealing with something that which is tangible, which is sure of. We are not. We can't take these chances of mothers and babies. And because of that, of course, Ministry of Health will change the guidelines in according to WHO, but probably in the near future. Yeah? Okay, thank you.
Okay, would Dr.C would like to add on to that?
Yes, Dr. Hishamshah. At the moment, the evidence from the SARS back in 2003 shows that none of the mothers who were pregnant and had delivery, there was no vertical transmission from that year. And the evidence also from the breastfeeding from that time, 2003, did not show any transmission through the breast milk, and the breast milk samples were all negative. And we are seeing some early evidence from a few case reports that the breast milk is actually also negative, apart from the placental swabs, the amniotic fluid swabs, the vaginal swabs, all were negative. What we are worried about in Malaysia is the horizontal transmission from the mother to the baby. If the baby is sent to the mother in the ward, of course, the British and the related guidelines advocate the use of masks cleaning the breast before the baby is latched on. But those kind of evidence at this time of pandemic, can be quite arbitrary and may not be something that is in line with infection control. So until more evidence comes out from more centers, especially those one advocating liberal use of breast milk and on everything, then at the moment I think we are taking it safe and following the fifth edition of the ministry guidelines. And at the moment so far we have not had any horizontal transmission from these practices by keeping the baby from the mom and so on and so forth. But some of the evidence that occurred from the SARS time when there was a debate about these practices of that the use of pasteurization of breast milk can be something which is practical and solves the conundrum of this breastfeeding issue in a viral pandemic like this. That is my opinion in this matter. Thank you.
Okay, the take-home message is continue to breastfeed the babies, please. I think the benefit probably at the moment like it is something that unknown, that is better to be cautious, yeah. Okay, do we have any dissenting views? Yeah, because you actually have things out in open, so that the whole world will listen to you guys. So can somebody just shout it out? Do not breastfeed the babies if you are convinced it is actually COVID positive.
Do not breastfeed the baby until you are good.
Okay, is that all clear? Okay, this is very important. Dr. Tan, anything from you, short one, before we go on?
I think what our obstetric colleague mentioned, I think it's important we need to document COVID-19 negativity in the mother who wants to breastfeed. And since we are already monitoring the PCR, if the PCR is 2 times negative, of course, obviously, the risk of transmission would be obviously not there. And as you mentioned, as Dr.See has mentioned earlier, I think there are some recent studies suggesting that there's no evidence of the COVID-19 virus being detected in the breast milk. So once the mother has zero reverted to negative, it should be quite safe then.
Okay, so clear? Everybody's clear now? Okay, thank you very much. Okay, the next question that people want to ask, people on the front line, how do you auscultate when you're wearing the full PPE or the PAPR? Can maybe who's handling the ICU patients? Dr.See or maybe Dr.Thahira? How do you auscultate patients when you're wearing the full PPE?
I've not personally used PAPR, but if you're using full PPE, you can still able to auscultate quite well. PAPR I have no experience with this.
Okay, PAPR is the one with that tubes coming out from the head. Yeah, I don't know.
Yes.
Yeah. Never used that before. So, Dr.See, have you actually used that before?
Not at the moment, Dr. Hisham, because all the babies have not needed any intubation. But we stand by at the OT if you need to. And in the time that they are waiting for the treatment on, they are ready with their airbags and their.
Whether you can see this or not, that's a PAPR. Maybe the obstetrician in the maternity OT have you used this? Anesthetics. I didn't use the PAPR.
People use PAPR, but while doing the CPA section, so auscultation was an issue. But when you use a PPE and when you see COVID patients, sometimes you do need to auscultate. But you have to remember that your stethoscopes are clean until you touch the patient. You clean your equipment within the patient. And the equipment is clean. There's no issue. You can put in your stethoscope your PPE. And then when after you examine the patient, you have to sterilize the equipment again, like I said, sterilization of equipment. You can't wrap your stethoscope, but you can clean the stethoscope afterwards.
Yeah. We can't hear you quite clearly. I mean, can you actually bring the microphone nearer to you? Yeah. So what I'm trying, the thing that I can listen here is actually saying, Dr. Hannah saying that you have to clean your stethoscope before using the stethoscope on your patients.
In between patients, you do have to clean all your documentation. So your
that is the take-home message, clean your stethoscope and then do it properly, because otherwise you will be actually transmitting the virus from one patient to the other. Okay, that's actually standard of care, especially now.
in for each patient, usually in like in ICU, we have one stethoscope with that patient. We do not take the lady stethoscope and do another patient with the same stethoscope.
Exactly. So make sure that the universal precaution, making sure that infection control is strictly adhered to. Yeah, I mean the one you use a stethoscope for the patient, that one is reserved for that patient alone. So we shall move on. Almost 70 to 80% of the pediatric patients are admitted due to ALI or ILI. Do you routinely recommend COVID-19 screening for all pneumonia or SARI even without positive contact? Maybe Dr.Thahira can answer that. Do you now screen for COVID-19 for all such patients?
Okay. Ideally, doctor, if you're living in ideal world, yes, I would recommend that. But right now, our lab cannot process current demand. So I still think at this point in time, we still need to screen who are we doing the test for, and when there's any indication in that, discuss with ID physician.
Okay, I think now the index of suspicion must be very high. If you suspect this one may be COVID-19, you do the screen.
Yes.
In the ideal setting, you will screen all such patients. Yes, so that was in idea, but you need to actually look at the situation on the ground. But I think the guidelines now, those who are in the ICU, consider them as potential COVID positive patients, yeah?
Yes.
And they should be screened as well. Okay, we shall move on to the next question in the interest of time. For COVID-19 designated hospitals, it is clear, but how about in non-COVID hospitals? Should we treat all SARI as positive? Who would like to take that on? Dr. Thahira, because you are the ID pediatrician or maybe. Okay, I see Dr. Hannah there. Is it Dr. Hannah or Dr. Norashikin?
You look similar.
Oh, similar, yeah, because we got mask, so I cannot see you. You are identical twins. Yeah, okay.
For non-COVID hospitals, okay, for
okay, thank you. Okay, right. For non-COVID-19 designated, of course, for non-COVID hospitals, we actually discuss with our ID physician.
Okay.
So the decision or the leader of a non-COVID hospital is still an ID physician. Depending on the discussion and a conclusion will then be reached. Then we will decide that the patient is actually a SARI or not. But again, for OMC, we decide what our decision is also made together with the physician, not just on our part. Thank you.
Okay, so discuss this with your physician and come to a conclusion, yeah? Okay, that is the other question also. Yeah? The other question from Dr. Angeline Mohd, I think, from Siblings. This one is directed to Dr.C. Neonatologist to neonatologist. So he has mentioned that during LSTF, during C-section, the pediatrics team will wait outside the OT. What if resuscitation is needed in the OT? Is there time for the pediatrics MO to don the PPE and run in to resuscitate the PPE? Question for you?
No, Dr. Hisham, we are actually in the OT, but at the different part of the OT at the back, with our open doors and our PPEs. So we are actually ready. It's not actually outside the OT. We have passed the airlock. We are also already in the OT and inside there. So, yeah.
Yeah, okay. So you hear that, Dr. Angeline? They are ready. They are already with the PPE and they are inside the OT and within the airlock, so they are okay. Once it is actually out, then they are going to actually go in and help the baby if they require resuscitation. Okay, the other one from Anonymous. This is also a pediatric question. If we are treating pediatric SARI or ERI as COVID positive until proven otherwise, does this mean we swap them, isolate, and full PPE? So I shall probably ask Dr. Thahira from Hospital Tunku Aziza, how would you do this?
Okay, for all children who come in with ERI symptoms, I always tell people to isolate them in the cubicle. So anybody who enter the cubicle should be at least wearing a 3-ply mask before entering the patient cubicle to manage these children. And if you are saying this is SARI, then I expect the child to be placed in the single room isolation and for the doctor to use at least 3-ply mask. And for the nurses who performing the swabs to wear a full PPE, full sleeve, water repellent gown, N95 mask, and also face shield before they take the sample. So that if test came back positive, we have to close ward or close the hospitals.
Okay. So that's actually the way we actually handle if patient was suspected with COVID positive. Okay, the other question, we've got a lot of questions, we've got 60 questions and numbers are climbing. We have only about 20 minutes, so yeah, you can stay on. Okay. The next question is regards to treatment, yeah? When should we initiate otenavir and ritonavir, which is Caletra, and hydroxychloroquine? So what is actually the algorithm? When should you initiate this treatment? I think probably Dr. Thahira, because you are treating patients. Can you answer that?
Okay, since it's a novel disease and then most of the report is only big evidence base, it's quite difficult to formulate clinical decision. Even in US and Europe, among the critical care society, they are against using ritonavir and also lopinavir with hydroxychloroquine even in their critically ill adult. So my tip will be in the children who may be in ICU with maybe stage 4 or stage 5. If you want to use, the only thing we have at this point in time is hydroxychloroquine. And later when you have the remdesivir or favipiravir, then you have other choice.
Okay. The other question is, I think probably this is for Dr.C, because it's newborn. In hospitals with shortage of PPE, should newborns be kept MPO until result is out, which usually takes about 48 hours, or continue with 3-hour feeds but start wearing basic PPE only? What is your practice in Sg.Buloh?
Now, in this group of babies, we have two groups. One, we have the preterm delivery, and then the other one was a term baby. Of course, in the preterm ones, then you have to follow your in feeding your premature babies. You may not be full feeding, and you might have to start at certain protocols. Just for the term babies that we have so far, we have not kept them milk by mouth at any time. For us, these babies are actually well. The risk of vertical transmission is very low. So at no time do we feed them milk by mouth. We feed them after they have gone through the what we call it, top and tail, given the vitamin D's, fatties, and stabilized, and it's needed the moment they are all ready for the feeding. It's just that like we discussed just now, the type of feeding that is of an issue of controversy at the moment. But as for feeding them by mouth, I don't think that's something we practice even in non-COVID babies. So in this time, we are feeding most of them, even the ones which are stable, the premature ones. We also starting feeding quite early nowadays. Thank you.
Okay, please feed your babies, yeah? Don't overfeed them, especially the one in MCO. Please watch your diet, otherwise you will be very fat and overweight. Okay, the next question. Hi, Dr.Thahira and Dr.See, to both of you. Would the cardiac arrest protocol be similar to the protocol in adults? Can you answer that? I don't think there's any cardiac arrest yet, in pediatrics. So, I mean, if there's a cardiac arrest, would you use the same cardiac arrest protocol in adults as in the
Yes,
adults?
doctor, it will be the same.
Okay. Move on.
And also for the NRP, it will be the same. It's just that you have to follow certain things which I've discussed just now in terms of using the self-inflating bags with the viral filters and the PAPRs. You need to go to aerosol generating procedure. So at any time, please protect yourselves and follow the training that you have been given before you go into the OT or the labor room to resuscitate these babies.
Okay. So in any procedures where there's a high chance of aerosolization, please, use the proper protective garments and your PPE must be in place. Yeah. So regardless of the situation, if it is a COVID positive patient, you have to protect yourself first. Yeah. Okay, this is the question from the district. In the district hospital, do we need to screen for COVID-19 for patients with clinical features suggesting bronchiolitis? Maybe Dr. Tan can respond to that in the district hospital.
Yeah, I think under the current situation, obviously, if the patient has features of bronchiolitis, we also know that most of these wheezing episodes are more likely to be, I would think, non-COVID-19 than COVID-19 under the present circumstances. Most will present with consolidation rather than air trapping. Should you screen for COVID-19? I would say if you are quite comfortable with the clinical diagnosis of bronchiolitis, probably I think the most common organism will still be RSV, followed by other influenza virus infection. But having said so, we cannot exclude the possibility of community transmission, which does happen across the country, we know from our data. I would like to say this would be a case-to-case basis. Probably would have to discuss with the ID pediatrician before a decision is made, because testing kits are quite limited. Of course, it would be ideal to test those kind of babies as well, but we go by the most common organisms for bronchiolitis will still be RSV.
Okay, so there's a question with the commonness is still RSV, but depends. If you are coming from a COVID positive area response, then I would presume that you want to screen these babies with bronchiolitis.
Yes.
Yeah. Okay, so clinical judgment is very important. If you have a high index of suspicion this might be a COVID positive, then please do screen these patients for COVID-19. Okay, the next is for non-IT hospitals, how to handle all the VHG records written in the PUI wards. Should we copy it and dispose those contaminated documents? Okay, this one is actually people concerned with the paper document, whether can the COVID-19 virus, SARS-CoV-2, survive the paper. Maybe Dr. Tan can advise us on that. Do you think you need to, decontaminate or sterilize the documents, or what?
There is an interesting study from US CDC, and also some studies from the National Center for Infectious Disease in Singapore, I think published about 3 weeks ago. There seem to be good clinical evidence to suggest that there is heavy contamination in the room of patients with COVID-19. I think these are already proven. So obviously there is a risk of contamination of the records. So if it is a paper record, well, how do you disinfect it? It can be quite tricky. But some studies from University of Nebraska Medical Center seems to suggest that ultraviolet light will be able to kill the virus. So that could
Can
be
I ask Hosp.Sg.Buloh and HTA? I mean, how do you deal with the records? How do you handle the contamination issues on the formats and also in the wards of patients with COVID? Is there any standard operating procedures?
Yes, doctor. Since we are looking after the cases in HKL, the old building, so we are using a lot of paper in DHT. So the trick is not to bring all this DHT paper inside the patient area. It's all left outside. You only go in your stethoscope and nothing else with you. So everything is outside the pink zone, not yellow or red zone. So then your records will not be contaminated.
Okay, that's another way. Don't bring your paper records into the COVID positive room, Leave it outside and you just bring yourself an essential instrument. Then after you're done with your examination, then you go outside and print yourself before you actually write on your VHT or entering data into the computer system, into the HIS. Is that the same
for PUI?
Yeah, okay, all the PUI as well. Is Hosp.Buloh doing the same way because you're entering data into your HIS system?
From Hosp.Buloh, basically we do the same thing. We do not bring any notes into the dirty areas, the contaminated areas. So if we do need to write anything or the patient needs to write something, what we do is they write on a piece of paper in the room and we sort of stick it on the glass wall. So the person outside will have a view of the notes, and if the notes are inside the room, we dispose and destroy the notes in the room. So whatever notes that are written on a piece of paper, stick it on the glass wall. The person outside which is not contaminated copies the notes.
Okay. So that's another way. So you separate those who are inside and those who are outside. So you can actually make sure that the contamination is within only that restricted area. So that's another strategy. So we move on. Okay, the other thing is, does patient less than 6 years old with COVID-19 positive, who are COVID-19 positive, and then you've got the parents who are COVID negative. So the baby is, the child is COVID positive, and both parents are COVID negative. How would you handle this patient? Who is taking care of the patient then? Because both parents are negative, but the patients are positive. How do you manage those patients in the hospital?
From the first guideline, doctor, we already stipulated that one guardian will look after the child, is either the mother or the father, and they have to strictly adhere to the measures, wearing masks and also washing their hands. So one parent is allowed.
So meaning that if one of the COVID negative parent must actually be assigned as the caregiver and stay with the baby or the child. So that's the current guideline. Okay, thank you. Is that the same thing in the neonatal ward?
Yeah, Dr.Hishamshah. So neonatal ward is different because we are totally the only neonatal COVID ward in the country at the moment. So it's totally out of bounds for the parents. But we will send them images from their phones so that the mom can have a look. So until they are clear, they can't see the babies. But what we have experienced in our stage 1 and 2 general case what the case of COVID is that from the first case that was admitted here on the 25th of January, the pastor from the Chinese tourists from Singapore, that we get the mother to say this was very unique. We have the two child, 20 months old and 11 years old, plus mother which cannot be separated, plus his grandmother, who was 65, I think, last years old. So all four of them were in the same room because they have to be separated. Of course, the elderly grandmother has to be taken care of by the mother, and the other two kids just couldn't leave the mother. So the mother initially was negative. Of course, after staying there for close to 2 weeks, she also became positive. So despite whatever measures we have in place about the masks and about hand washing and everything, it's just very difficult for parents, and especially when you have a child who's actually positive. but you are actually negative and you have no one to actually take care of your kids. So at any stage, we have a lot of variants of these arrangements. We even have, Caucasian parents who are actually positive with one child who is positive, two other children who are negative. So they all together come in the same room because who want to take care of the child if you have direct contact with a positive case, isn't it? So that is the interesting facts about pediatric wards compared to the adult wards where you can actually isolate everyone based on their condition. But in pediatrics, cases, and every day it's very interesting to see how family dynamics actually play out in this COVID era. Thank you.
Okay, that's actually very sad, in a sense. But you see, the mother would do anything for the child. They are negative, but the child is positive, then they would actually sacrifice. So that's why we should value our mothers. Okay, just a message, Okay, the other thing that people were asking, this is an anonymous question. If we were to treat all SARI patients in ICU as possible COVID, does that mean we can't use non-invasive ventilation if these patients require such support? And are we supposed to intubate all patients who require intubation, all SARI patients? Can anyone answer that? I mean, this is, I don't know whether pediatric patients are ventilated. I mean, can you give at least some guidance on that?
Okay. The reason why people are to use NIV is because might also generate aerosol. So there's a risk for healthcare worker. But saying that, we must do what is best for the patient. So if you think the child needs intubation, then go ahead. If you think the child can have NIV and there's nothing except for SARI, no close contact or any adult come positive, or no history suggests that this can be a potential COVID, then we treat the child as we manage any other child with pneumonia. At this point, the guidelines still have criteria when you suspect if somebody is COVID. So it's there in our new fifth version of the guideline.
Okay, the fifth version of the guideline is available to download at the MOH website.
Yes, it is.
Okay, please go to the MOH website and download the guidelines, which is actually freely available. Yeah. As much as possible, the guideline says that you should not use non-invasive because there is a risk of aerosolization. But I mean, if you need to intubate the patient, then we use the invasive, the NIV. Yeah. Okay, the next question. I see a name there, Dr. Azira, asking a question to Dr.See. Dr.See, just to re-clarify about the humidifier. Do you use HME or heated humidifier ventilating the neonatal facilities?
We are in line with the announced ICUs that we are not using any humidifiers for the ventilated patients. And at the moment, we are having our setup here so that we are following the same thing. So we are using the HMEs, which are the heat and the moisture exchange system, and we are using a viral filter on top of it. So this is in contrast to the normal humidifiers we use for our neonatal ventilators. So in COVID and ICU settings, we can't use that. So you have to modify your machine, or you have to get machines which does not need humidifiers so that you can use the HMEs plus the viral filters. So it's just a tweak of the common things that you actually do in the ICU. It's quite simple. Yeah, thank you.
Okay, so that's the question. The other one is a significant percentage of babies born through C-section have this transient tachypnea of newborn. Most of them will need CPAP for a very brief period. So this is for the neonatologist. Would you intubate them or offer this group of patients CPAP?
Of course, if you use CPAP, you will also have the humidifiers there. And at the moment, it's not recommended as a form of support. It's actually an NIV kind of a support at the moment. So, so far we have been lucky. We don't have any, but in the case they need and they have respiratory distress, probably we will intubate them early. And to talk about the NIV thing, of course, the amount of babies and also pediatrics that will require escalation of care to incubation is actually very low in Chinese cohort and also the studies in SARS. But we extrapolate from the adult studies. What the adults found is that apart from that, the NIV and the HFNO, high flow nasal oxygen, is actually causes hospitalizations. We also found that time was wasted giving the NIV in these group of patients when they should have been intubated early. And they found that the mortality rate at the end of the day is almost similar when you use NIV or even intubate them early. So based on this, most intensivists now would actually intubate early rather than using NIV and delaying the time from respiratory distress to stabilization. And this is one of the things that is common in Hosp.Sg.Buloh in the adult ICU at the moment. Hopefully, we don't have many pediatric patients with that, but we already have a protocol in place. Should they need escalation of care, we will intubate them. Thank you.
Okay, so we try to actually avoid using NIV, and intubate them early rather than later. Okay, the other question from the College of Surgeons, regarding College of Surgeons suggesting to treat all emergency surgery as COVID-19 positive, including C-section, How can we do this in non-COVID hospital? That is non-COVID hospital, treat all emergency surgery as COVID-19 positive.
Hi, I'm from Hosp.Sg.Buloh on behalf of ONG. So I think it would be a bit of an overkill if we're going to treat all patients actually that come in for any form of surgery as COVID positive. So I think what we need to actually do is again our history taking, and although we have had cases which have not actually been very honest about the history in terms of contact, I think what we need to practice now is standard PPE for any patient that we are using. So I think what we could be doing is using disposable gowns and things like that when we have to do a surgery when we are not too sure about the history of contact. But if you're going to use full PAPR and full-on PPEs for every single surgery that we do, in a situation where PPE is not that readily available and we're having difficulty getting it, although we have got some now, I think it will really be an overkill, and really we will be using resources in the wrong, for the wrong cases, and then when we actually need it, we might actually run out of it. So I think it has to be case-to-case basis. We actually have to see the significance in history, contact, and things like that before we actually decide to designate whether they are a PUI or they are not, and if we are quite sure that they are not, we can just proceed as with any other normal patient.
Okay, we are clear with that. Okay. The next question. All pneumonia will need COVID PCR as well, I suppose, in a sense. While waiting for the COVID result, labs in small hospital will stop doing all respiratory samples and blood gas, so management is difficult. So in the district, this is in a district hospital, and if you are going to actually treat all pneumonia as COVID positive, while waiting for the result, how would you treat the samples, the respiratory sample and also the blood gas management is difficult. I think this is someone from the district. So how would you address that? Maybe Dr. Tan can explain how would someone in the district hospital approach this?
Well, whether it is under the present COVID-19 pandemic or non-COVID-19 as previously we've been doing all along, I think standard precautions should apply to all these sampling of the procedures. There shouldn't be any special differentiation between COVID-19 and non-COVID-19 because we wouldn't really know whether it is in the first place. So I think standard precautions should apply.
Okay, so we treat all samples as a universal precaution and do that, Okay, this is another question to Dr. Nora. ACOG suggested to leave the vertex on the newborn for 24 hours based on expert opinion because it has antimicrobial peptides. So do you recommend that to keep the vernix on the newborn for 24 hours?
Okay. The question regarding this is, again, this is expert opinion. It's not based on clear clinical evidence. Therefore, in this time and age of unsurety, we will always take the safer side for the baby. Meaning that, together with our neonatal clinic, we follow the standard protocol. That means we not entail and clean the babies. We do not use the vernix on the newborn for 24 hours. Thank you.
Okay, so this is another question to Dr. Thahira. Why was the COVID treatment given to patient 1 while the patient 2 was not given COVID treatment? Can you answer that?
That is the question, Doctor. Which question? Oh.
Yeah, that question. Yeah.
Which one? Why
one and didn't give.
Okay, there was my first case. Is also a learning curve for me. So now looking back, I would not treated the patient. I would have waited.
Okay, so that's the answer. I'm just trying to choose.
The system will only choose those for one patient on top. The similar one they go down, so not so many priorities. So maybe we can close one or two more patients. We can close.
Okay, you'll see one more or two questions because it is rolling up. Not sure which one. It's not stopping. My eyes are getting, tired. The other one is, when do you discharge COVID-19 positive postpartum baby? Yeah, when do you discharge COVID-19 positive postpartum baby?
When the swabs become negative.
Okay, when the swab becomes negative, 24 hours apart. Okay, so then the other one is actually using does humidifier use on nasoprom cause aerosolization? So humidifier use on nasoprom, does it cause aerosolization?
Of course it does. If you're using the high flow nasal cannulas, it's same like your vapor or your humidified high flow nasal cannula that you're using already in your NICU. So if you're using just nasal prom without humidification and it does that should be okay. But if you're using humidifiers along with it, then of course it generates aerosolization and that's not recommended.
Okay, I think we're short of time. Unfortunately, I know. There's a lot of questions there. It is going up and down. What's going to happen is we're going to actually collect the question and we're going to actually answer the question and put it up in the website for the experts to actually give the answer. And you all can actually go to the website and see the questions.
We also have a summary of the discussion.
Okay. And the organizers are also going to actually get the summary of the presentation and also the question so that we can actually review back what was being discussed during this clinical update of COVID-19.
Thank the international.
So I think I would like to thank everyone, especially those who are coming from abroad, the international audience, for joining in the discussion. This is actually our third series, is the clinical updates with COVID-19. We're going to do it every week. And we are seeing that there's a lot of interaction over 5 continents. Yeah, and they're also looking and learning from the summary. I think that's a very positive thing coming out from this COVID-19 because this is something very new and sometimes experience of people are not well documented and also shared. I think we should actually keep on doing this kind of exercise. Yeah. Dr. Thahira, how are you? Okay, I think last but not least, I would like to thank all of our panel members today, Dr.Norashikin and also Dr. Nohana and also Dr.See in Hosp.Sg.Buloh. Stay strong, keep up the good work. And thank you, and also Dr.Thahira, Jamal, Mohamed in Hospital Tunku Aziza and in Kuala Lumpur, and also Dr.Tan who's joining us from Sarawak. Propaganda University. Thank you very much for actually contributing to this very useful discussion. We hope to see you guys again next week for another segment of our updates in COVID-19. So, Assalamualaikum and good afternoon. Thank you everyone. Keep safe, stay at home, stay strong for Malaysia. Thank you. Bye. Bye.
Bye.